Good morning, everyone. I'd like to discuss about a cryptogenic stroke in a young patient whom we managed at Apollo Madurai. This was a 29-year-old lady who was a cath lab nurse by profession. She had recurrent strokes despite being on dual antiplatelets. She had a history of 3 abortions. She was APLA positive and vasculitis workup was done. The cause of cryptogenic stroke in young patients include embolic and non-embolic causes. Embolic is primarily because of atrial fibrillation and other cardioembolic reasons. Apart from that, there is artery-to-artery embolism, systemic hypercoagulability state, which was suspected in our patient since she was young, and non-embolic causes like vasospasm, in situ thrombus, and impaired hemodynamics. There is a terminology called ESUS, which is uh, embolic stroke of undetermined source. The difference between cryptogenic and ESUS, in ESUS, the cause is really not known, whereas in cryptogenic, the cause is not known. Whereas in ESUS, though it is not known, it is a subset of cryptogenic stroke in which it is more likely to be embolic in origin. So this is a MRI in this patient. Diffusion weighted images show that there were areas of acute infarcts which was seen in the centrum semioval and the right frontal lobe. FLAR shows that there were prior histories of right frontal lobe and right temporal lobe infarcts. On MRI angio, we are able to see that there was areas of narrowing which was seen in the right middle cerebral artery, which were with attenuated signal intensity of the M1, M2 segments. CT angio was done in the conventional imaging, in the 3D MIP images and volume render images. There was a focal area of defect which was seen in the CT angio, whereas in coronal angio, we are able to see a small interluminal protrusion. The diagnosis was picked up in the source images, which were axial CT angio images and oblique sagittal images. Here we are able to see a linear filling defect which was seen within the proximal right intercarotid artery close to the carotid bulb. And here again we are able to see a linear shelf-like filling defect which was seen arising from the posterior wall of the right intercarotid artery. On retrospective imaging and visualization of the color Doppler, we were able to see that there was a small plaque, small fibrous echogenic lesion, which was causing areas of irising, and it was protruding within the lumen. This was a MRI. This is the DSA images. Here we are able to see. Let me just run the video. Yeah, here we are able to see. This is the right ICR, and we are able to see that there is a area of shelf-like defect which is seen arising from the posterior wall of the right intercarotid artery. There is a small thrombus which is adherent to the superior part of the shelf of the leaf. This is basically a carotid web, and this is the thrombus which is adherent to the superior aspect of the carotid web. Right middle cerebral artery run, though it was attenuated in the MR angiograph, MR angio images, in DSA it was appearing normal. This is the contralateral left IC run, which was normal. And here we are able to see this particular thing is causing slow or relatively narrowed flow which was seen across the lesion. There was at least 50% narrowing which was seen, and here we are able to see the entire contrast is getting flushed up. The posterior aspect of the right carotid artery, there is sluggish flow or there is delayed passage of contrast. This is the reason why there is embolic phenomena which occurs because of slow flow within the carotid web. So a stenting was done. This is post stenting images. Here we are able to see it is immediately getting washed off. So what is carotid wave? Basically, it is a variant of fibromuscular dysplasia. It is not an atherosclerotic plaque. As in our case, it is a thin triangular membrane which is usually arising from the posterior wall of the intercarotid artery. It's typically seen in patients who are less than 40-50 years, more commonly in women. This frequently there is no history of hypertension, diabetes, or hyperlipidemia, but nowadays they say hypertension is also one of the causes of carotid web. Disproportionately associated with recurrent strokes or antiplatelet therapy. What is the imaging findings we see in carotid web? It is a shelf-like filling defect at the carotid bulb, usually arising from the posterior wall, best seen in sagittal or oblique views. In the volume rendered and the 3D MIP images, it usually gets missed off. MR angiogram, we might not be able to pick it up. Duplex ultrasound can be normal and non-specific. Only on retrospective imaging, we'll be able to, second look, we'll be able to see the shelf. DSA is supposed to be the gold standard. The management includes medical therapy and definitive therapy. In medical therapy, antiplatelet therapy and anticoagulants are given. Antiplatelet therapy includes aspirin plus or minus dual therapy. However, the definitive therapy is going to be carotid endarterectomy or carotid stenting. Carotid stenting excludes the web from the lumen. As in our patient, we are able to see the stent oppose the web across the wall of the intercarotid artery. Intervention is usually favored for symptomatic carotid webs. So asymptomatic patients may be asymptomatic patients, and initial therapies, medical therapy is acceptable, whereas medical therapy alone is not sufficient for symptomatic recurrent patients. So this is a very good article published by the Imperial College of London, which has a highest case series of around 771 patients in which carotid web is being was managed. So this is a good article to go through. This is a picture which was seen from this article. Here we are able to see the carotid web which is seen here. So what exactly happens in a case of carotid web is, because of the shelf-like defect, there is a stasis of flow which occurs. Instead of going superiorly, there is a sluggish stasis flow which is seen on the superior aspect of the carotid web, which results in thrombus formation. This was proved by 4D flow MRI images, which was done by the University School of Medicine by Emory. Here we are able to see this is a 4D flow MRI. The blue is the lower scale. So on the superior aspect of the web, there is sluggish flow or stasis flow which is documented, and this leads to the thrombus formation. And so coming to the other differentials for interluminal filling defect, as radiology consultants and students, we need to know there are 5 important causes. The most important is atherosclerotic plaque, where we see bulky lesions, calcified, non-calcified, fibrous tissue, lipid-laden plaques which are seen. This usually leads to tight stenosis, which causes thromboembolic phenomena as well as high-grade stenosis. Whereas the other reasons for this is interluminal thrombus. So here we are able to see that there is an irregular low attenuation defect which is seen at the carotid bulb. This is an emergency finding, and it has a high embolic risk of causing stroke. It can be acute or chronic. The third important cause is what we saw today, which is a carotid web, which is a small shelf-like defect which is seen in the posterior carotid web. There is no stenosis. It is more of the embolic phenomenon which is occurring on the superior aspect of the carotid shelf, which is leading to, though it is actually causing around 50% stenosis in majority of the patients. Other important causes are arterial dissection, which we commonly see in patients who have a history of trauma or neck pain and headache, and in which we are able to see the flame shaped kind of an appearance. The difference between true dissection and true occlusion and false occlusion is, if it is an abrupt cutoff, it is true occlusion, whereas pseudo occlusion will be having a water pink kind of appearance, which can be seen in case of a terminus ICA occlusion. FMD is other important cause. It will usually be in the mid and distal ICA, where we see a string of bird appearance. So to summarize, thin shelf life, it is carotid web. Thick, large things, it is usually a thrombus. Bulky calcified plaques is what we routinely see, which is a plaque. Taper narrowing with a flap is dissection. In irregular artery with a beaded kind of appearance is going to be fibromuscular dysplasia. So coming to what exactly is the incidence of carotid web, it is normally seen in less than 1% of the general population. And in cryptogenic ischemic strokes, it constitutes nearly 20%, 10 to 15% of the strokes. We need to understand in ischemic stroke, even despite the best evaluation, nearly 30% of the cases are can turn out to be without an identified cause, and this constitutes to 15% of the cryptogenic ischemic stroke. And in young patients who have cryptogenic stroke, then it has a higher prevalence of around 20%. So this is a good article on the frequency of carotid web. So it is these days getting more and more picked up. My sincere acknowledgement to the IR team, radio diagnosis team, neurology team, IC team, anesthesia team, and emergency team. Thank you.